Hello, everybody. I'm Dr. Chevalier, and I'm a polycystic kidney disease specialist in New York City. I'm going to talk about Farabursen. It's a new investigational medicine for people with polycystic kidney disease. So today I want to give one disclaimer that I will be summarizing publicly available data. This talk is not intended to be a recruitment effort for any clinical trial. So here's a brief outline of what we're going to talk about. We're going to talk a little bit about the background of like how genes make proteins, what goes on in ADPKD, what microRNA is. We'll talk a little bit about Farabursen. We will talk about the trial, and I will have some questions and answers that I've already been given that I will try to answer. All right. So one of the things that we want to establish is in order to function normally, the body really needs all the raw materials in order to build healthy kidneys. So let's talk a little bit about background. A gene is a little piece of DNA that tells the body how to make proteins. The purpose of every gene in your body is to make a protein. Your body needs each and every one of these proteins in order to function normally. The PKD gene is a gene that every human has, and the PKD gene makes a protein called polycystin. This polycystin protein is needed for people to make normal kidneys. If a person does not have enough polycystin, they will make cysts in their kidneys. Now, what happens in people who have PKD? One of their two PKD genes is mutated, and that mutated gene cannot make the polycystin protein. Now, in about 90% of people who have PKD, the abnormal gene is called PKD or PKD1, and the proteins made by these genes are called polycystin 1 and polycystin 2, respectively. Now, just to make it simple, for the rest of this talk, we're just going to say PKD gene or polycystin. In reality, people have a PKD1 gene mutation that can't make polycystin 1 or a PKD2 gene mutation that can't make enough polycystin 2. But like I said, we're just going to say PKD gene and polycystin to make it easier. So once again, in people who have PKD, they don't have enough polycystin. So in their body, they start to get cysts in their kidneys, their liver, their spleen, their pancreas. Their kidney function starts to worsen. They could get blood vessel problems and other things associated with abnormalities of the PKD gene. All right, so on the right, you will see someone who is normal. This person does not have PKD. This person has two normal PKD genes, and this person makes 100% of the polycystin that they need in order to make normal kidneys. Now, on the right, you'll see that someone with PKD has one good PKD gene that usually comes from the parent without PKD, and one bad or mutated PKD gene that usually comes from the parent with PKD. So if someone with PKD has one normal PKD gene, you might expect that this person will make half or 50% of what somebody with two normal genes makes. The problem is that's not true. The actual amount of polycystin made by somebody with PKD is much less than 50%. The more aggressive or severe the PKD is, the less polycystin you make. Why so little? Well, the answer is something called microRNA. I've been explaining this microRNA like nature's braking system. So microRNA are little pieces of RNA. Just like the brakes on your car stop your car, these microRNA brakes stop the genes from making too much of a protein so that they don't waste their resources. For those of you that know, this is actually what the brakes on your car look like. And this is a picture of what the brakes on your car look like. So for the rest of this talk, I'm going to use this symbol, this brakes symbol, to represent the microRNA brakes that stop the gene from making a protein. All right, on the left, once again, we have somebody who's normal. They have two normal PKD genes. They do not have PKD. They have a normal amount of these microRNA breaks, and they make enough or a normal amount of the polycystin protein. Because they have enough polycystin protein, they make normal kidneys. In someone who has PKD, the mutated gene causes the body to make way too many of these microRNA breaks. Therefore, even the good PKD gene makes very little of the polycystin protein. Because someone with PKD does not make enough of this polycystin protein, they start to make cysts in their kidneys. Their kidney function gets worse, and in severe cases of PKD, someone could have kidney failure. The name of this microRNA in people that have PKD, or more specifically, in people who have a PKD gene making polycystin, the microRNA break is called microRNA 17. All right, so on the left, once again, we see the normal person has normal amounts of microRNA and has a normal amount of polycystin to make normal kidneys. In somebody with PKD, the one mutated gene causes the body to make way too much of the microRNA 17. They do not make enough polycystin protein, and they get cysts in their kidneys. The more severe this PKD gene mutation is, the more microRNA 17 they'll make, the less polycystin they'll make, and the more severe presentation of the PKD. This is usually what we call the Mayo class on the MRI of the abdomen, C, D, or E. You probably are familiar that this scale goes from A to E, A, B, C, D, E, with A being the least aggressive and E being the most aggressive. We consider C, D, and E to be aggressive forms of PKD. All right, now, what if we could block the microRNA 17 that's preventing the good PKD gene from making polycystin? These blue semicircles represent a medication. If we could make a medication that could block the blockers, that means that the good PKD gene could make more polycystin. In fact, now it could make enough polycystin that even someone with PKD would be able to have all the raw materials to make normal kidneys. So here is the most exciting part. Your body is constantly under construction. So just like your muscles, your hair, your skin are constantly being broken down and rebuilt, so are the kidneys. Now, if we're able to block the microRNA 17, and if we're able to give people with PKD enough polycystin, what we hope is that when they break down their PKD kidneys with cysts in them, and they start to regrow or rebuild their kidneys, that with enough polycystin, people with PKD will make normal kidneys, and people, instead of making the cysts in their kidneys. Now, this is still a theory, but this is what we hope will happen. All right. There is a new investigational medication called Farabursen. This Farabursen medicine blocks microRNA and appears to increase the polycystin levels, the raw materials needed to make normal kidneys, in people who have PKD. What do we know about Farabursen so far? So Farabursen is a shot that you give in your belly. It's a microRNA 17 inhibitor, and the shot is given under the skin every 2 weeks. So far, there's no evidence of kidney damage or gene damage from the Farabursen. The Farabursen was developed by a company called Regulus, who has, as of the time of this presentation, Regulus and a company called Novartis have entered into an acquisition agreement, meaning that Novartis is acquiring Regulus. This is not what the actual injection will look like. So what were the side effects that were reported in the phase 1 trial? I think a lot of people are familiar with the currently available medicine called Genarcu, generic name tolvaptan. Unlike Genarcu, Farabursen had no thirst and no increased urination. The only reported side effect in the preliminary phase 1 trial was pain, rash, or irritation at the site of the injection site that lasted for a few minutes, but it wasn't bad enough that most people stopped the trial. No other serious adverse effects associated with the medication were reported. So what are the results of this phase 1 research trial with Farabursen? Let's start with who are the people in the trial. The people were 18 to 70 with an average age in their late 40s, a little under 50 years old. The eGFR was somewhere between 30 and 90. The average was in the 50s. The people had what we consider severe or aggressive PKD with a C, D, or E on the MRI of the abdomen. They could have any gene mutation. 58 people got Farabursen and 10 got the placebo. The people in the study got shots every 2 weeks for 3 months, so the trial lasted for 3 months in the phase 1 trial. And the people who got the Farabursen had higher levels of the polycystin protein, just like we wanted. The kidneys did not grow for the people in the Farabursen group. The people in the placebo group had a small but expected increase in the growth of their kidneys. That's what we expect if we do not treat people who have C, D, or E or more aggressive PKD on their MRI. The Farabursen worked well for any gene mutation, and because of the good results of phase 1, the FDA has approved a phase 3 trial in humans. So they went straight from phase 1 to phase 3. All right, at this point, I wanted to say thank you. So every day I heard millions of slide presentations are given, and I hope that you liked this one. I did want to give a special thank you, a shout out to the team at Regulus, Claire, Preston, Rekha, and Ed for all of their help in making this talk. And I do want to let you know that we are here to help. If you still have questions, Susan, our PKD patient navigator, is available by phone or email to help with questions or to get in touch with us. Thank you, and I hope that you enjoyed.